Visions of the next 250. I'm here on behalf of my Neuroscience Institute colleagues at Mass General Brigham, where I've started to work in the digital and AI space. And we're really trying to consolidate a bunch of investigators who are trying to really improve the connection between physicians and scientists and their patients. And hopefully you're some of them, so we're going to talk about that today. So about 250 years ago, Massachusetts helped launch a revolution. And no one ever actually said the British are coming, by the way. If they did, they would have said the regulars are coming, because we were the British. The colonials didn't think of themselves not as British. So I'm going to try to convince you today that actually it's the humans who are coming, that AI is going to revolutionize care. I'm a neurologist, it'll revolutionize brain care, and what it's going to do is make our care more human. So on the night, April 18th, 1775, two lanterns appeared on the steeple of Old North Church, if you know the North End. Robert Newman, John Pulling, they climbed up and they lit this bell tower as part of this, one if by land, two if by sea story. But the sea at that time was the Charles River. And so, the British came there and they were headed out to find munitions. And so the colonialists who told this story and made that trip to stymie that plan, they did not necessarily win a war. They did something more fundamental. They really transformed a distant threat into an opportunity for the future. Okay, and so we are going to talk about that, today. Hopefully, yes. So Paul Revere's job wasn't to create the information. His job was to carry it. And in a way, we're going to talk about artificial intelligence as a way, as you saw, like two lanterns, one lantern, is going to be our way to interpret those signals and then learn also to orchestrate them. So who has been in this office before? Imagine I could give you this talk like this. How's it going? Right? So one goal that we've seen with AI is to give the provider back to the patient. So this is now what you'll see. You'll see a cell phone on the desk, listening and helping record the conversation, so the machine will carry that record and you can actually talk to someone in their face. But in reality, what % of time do you spend in your life in a doctor's office? Like some of you 0, some of you maybe one snapshot here and there. So our healthcare system asks patients to come to us at this scheduled moment, compress their life. Some people come with a list. And really, it's all happening at home. And you know what's happening to your mother or your sister or your daughter better than your physicians do. So what's going to happen, we're going to see in the future, is that we're going to be able to listen in, not on what exactly you're saying, but to hear your struggle. So this is what we call a spectrogram of speech. And what we can now do is use this to differentiate between patients who are affected by neurologic disease and patients who are not. So for example, the amount of time you participate in communication, how your speech is, your cadence, and how much content. And we can actually understand what your struggle is. And we would know, just like your family would know, if you're kind of having trouble before your doctor will. The same is true with your motor skills. These are movements of the arm over time as you're walking along. And we can see over a year of a patient, say, with ALS, we can see their own journey. You tap on your phone all the time. And actually, if we had a partner who was with you at your visit, could look over the way you're texting and typing, they would see that you are doing so a little less well than maybe you did a year ago. Okay, so our lives have totally transformed in the space outside the office, and the key is for us to bring our medical care into that space. That's even true for how we connect to people socially. So these are social maps in the top left of colleagues who've looked at how neurologic brain disease affects the networks that we live in and the people that we talk to, our social networks. And this is a cartoon that I designed of, this is Buckman Tavern. Originally, it was built by Ben Muzzy. It's up in Lexington. You can see outside, right next door to the Battle Green. It doesn't actually look like this because the buildings face the other way, but for all of us here, this is sort of a cartoon. Early morning, April 19th, this is where people at the time were gathering for a militia to sort of face a threat that was coming by sea. And so the nodes that people are gathering in those communities, we're gathering all the time. We're here together. And our map today is hyper-connected, right? But we need to help people understand, if their social network is deteriorating. Similarly, when we sit together in the doctor's office or the provider's office, we really want to chart a course together, and we want a map for that. So one of my colleagues in the audience today designed this map of sort of like a cockpit to help communicate with families of patients in coma. And you would always say, well, what are the numbers? And people would say, well, we can't really tell you. We're not really sure. It's sort of like, yeah. And now we actually have a dashboard. We started to study it in simulation. We're doing this in about 60 hours of interviews and trying to figure out if it's ready to go prime time. So this is the journey. And the finish line is right about now. This is work I presented that has been done in the past. And we really need to think of it as a starting point. So here is North Bridge. We now call it the Old North Bridge, but it wouldn't have been called North Bridge when the shot was heard around the world, as we would know from history. But that's where it happened, and you can go see that, April 19th in the morning. But really, we're going to cross that bridge to sort of a next generation, and it's going to be the visions of not where we are, but where we're going. So I'll show you a little bit of a picture into the future. Patients with spinal cord injury, or ALS, can now have implants that help them communicate. They can manipulate computers where their arms don't work. They can talk where their voice doesn't work, and we can actually look and see what their voice used to be, and now engineer so that voice is no longer a robot, but it's actually a human. Our surgeons who are doing brain surgery are going from seeing a tumor to actually being guided by, this is an ultrasound guided image of actually a tumor, so they know they can get the most out of it. We're going from discovering sort of treatments through trial and error, increasingly to now matching therapies to your biology in the room, and so that we can actually design something that's truly is personalized. And instead of applying for FDA approval like it's some finish line, this is actually an iterative process of co-design, where now the results are going to be tested in the lab, which is our bodies, our care, and we're going to see if things actually work. And then we're going to do that iteratively. From the patients who live in a community, and I said we could monitor them in that community, we're going to bring conversation back to people and actually socially engineer people to feel like they're more connected, because now we know when they're not, and we can deliver that to them. And when we go to see a physician, we're going to carry with that person not just their experience because they're gray, but we're going to carry that experience not just from their patients, from patients all around the country. And so, an example here, these are about 100,000 patients at our hospital who had EKGs done, and from about 300,000 of these EKGs from about 100,000 patients, we can actually look, see the dark blue parts of which are the highest risk, suggest they might have a stroke in the upcoming years. So we're going to go from that hidden risk to care. And the question is, I think for all of us, what are the principles we're going to do it by, right? So every revolution needs principles, and if we had sort of our Bill of Rights, there'd be 10 of them up there. I think a key to that is thinking about how we can sort of connect ourselves from being in that office space where we're sort of with a patient to sort of having an office without walls. And so from that, I think we'll transition to thinking about not just sort of an office without walls, but really about an institute without walls. So we're starting to look at connecting, say, our Mass General Brigham Neuroscience Institute to those around the country, so that we have sort of a free institute of learning health systems really without walls. So we're not just learning from the 10 patients I saw today or the 1,000 patients I've seen in my career, but from the hundreds of thousands of patients that all of us have seen together. So that is one vision for the next 250, and hope you'll join me there. We won't be there for all 250 of them, maybe another 50 for some of us. So thank you so much.